This lecture is going to cover pancreas pathology, specifically related to diffuse pancreas disease and the acute and chronic pancreatitis. Use the forward arrows to move to the next slide, or the back arrows to return to the slide that you were previously viewing. If you are using PowerPoint to view this presentation, make sure to open it in the slideshow mode. As you are navigating through the slides, you will see a pancreas icon. Click on it to hear more about the subject. YouTube users, the video will automatically play all sounds in key link terms. So for the next few slides, we're going to talk about pancreatitis, in particular acute pancreatitis. And acute pancreatitis is one of those things with ultrasound that you won't necessarily be able to say, yep, that's exactly acute pancreatitis, but you'll see the pancreas and you'll say, that looks a little weird. And what you really need to do is go back and look at their symptoms, look at their lab tests, and all of that combined is going to add to or kind of solidify the acute pancreatitis diagnosis. Now, in the end, the patient's definitely going to need a CT, and only time really will tell if it was acute pancreatitis, because as you'll learn, ultrasound isn't really all that awesome at seeing the pancreas, let alone diagnosing pancreatitis. We're much better at diagnosing focal fluid collections like pseudocysts or evaluating the common bile ducts, things that kind of can lead to pancreatitis or that might go along with pancreatitis. So remember to click on the pancreas icons for more information on each item. And if a section doesn't have a pancreas icon, then all you need to know is what's written on the pathology workbook. So remember that the pancreas has two functions. It has the endocrine function and it has the exocrine function. Endocrine, if you recall, is more hormonal, so it's substances that the pancreas just kind of puts out into the blood, where exocrine are things that are released through ducts. And pancreatitis is going to originate more in the exocrine system. So pancreas is the inflammation of the pancreas, specifically the Acini cells. Those are the ones that are creating the digestive juices. And what ends up happening is that those juices start to leak into the pancreas. So now the pancreas is kind of basically digesting itself. And then furthermore, that's going to leak further out into the body, and then it's going to cause a lot of issues as those really kind of corrosive digestive juices start to get in places that they're not meant to be. Now, as far as who gets pancreatitis, there's two things that you just have to remember. Number one is going to be biliary disease. So a stone typically comes out of the gallbladder, gets stuck in the common bile duct. So that's going to be our choledocholithiasis. And that stone being stuck in the common bile duct, especially the distal common bile duct, that's also then going to block the main pancreatic duct. And so that makes sense then, as the pancreas is trying to produce the digestive enzymes, it can't get out because of that stone, and then starts to block up and build up in the pancreas and starts to leak out. So that makes sense. The other one, though, is alcoholism. And alcoholism encourages the production of those enzymes to occur, and the body just has a hard time kind of dealing with the constant toxicity of the alcohol, and that starts to just really affect how your organs perform, and therefore can really affect the pancreas as well. Now, as far as how people feel when they have acute pancreatitis, it is actually pretty obvious. They are in a lot of pain. So it's going to be pain that's just right in the middle. So that's that epigastric pain. The other thing that they're going to probably have is a little bit of back pain. Nerves that go through the abdomen they come from the spine. So the pain just kind of follows those nerves back. And then they might also have some nausea and vomiting that go along with it. Now, we talked about biliary disease being the #1 cause. If biliary disease is related to the pancreatitis, what they're typically going to feel is very severe, localized, acute pain. And it's going to be like one spot they can point to, and it hurts right here. And that's most likely where that stone is going to be lodged and causing that pancreatitis. If it is alcohol-related pancreatitis, their pain is going to come on a little bit slower, and it's going to be more diffuse. So their whole abdomen is going to hurt versus just that one localized spot. So now lab tests up to this point have not been as important for a lot of the pathologies that we're learning, lab tests for acute pancreatitis are super important. So make sure that you understand how serum amylase and serum lipase can help to diagnose pancreatitis. So when a patient has acute pancreatitis, their serum amylase is going to rise very quickly, and it's going to spike, and then it's going to start falling back down into the normal range within 3 to 5 days. Where serum lipase is going to rise a little bit slower and have a spike well into their bout of acute pancreatitis, and then that's going to start to back off, and it doesn't really get better until that 8 to 14 day range. So we say that lipase is a better indication of pancreatitis because if a patient starts to have epigastric pain and maybe they aren't one to go to the doctor, or maybe they've got a lot of other things going on, they just don't equate that this is something that they should see the doctor for or have a blood draw for, they are going to miss that spike in amylase. So again, that has to be taken pretty quickly in the setting of acute pancreatitis to be seen as a high value because it starts to fall very quickly. Now, if we were to do blood work on a patient who had pain a couple days ago, now they're into the ER because the pain has continued to persist, we're going to run some blood work on them. If we see that that lipase is still elevated in that longer range after the initial onset of the acute pancreatitis, that helps to better solidify a diagnosis of pancreatitis. In this image of the pancreas, we can see that the pancreas is very heterogeneous. It appears to be a little more fluffy or edematous. It has more of a hypoechoic appearance to it, especially compared to the liver, and it has prominent vessels. Now, if you are using the liver to compare the pancreas to, remember that in the setting of alcoholism, the liver tends to be a little bit brighter, so the cause of the pancreatitis may hinder your sonographic evaluation when looking at the echogenicity of the pancreas. This image of the pancreas in the setting of acute pancreatitis shows us some swelling of the pancreas. So the pancreas may appear a little bit larger than what you're expecting. With the enlargement of the pancreas, it actually might be more visible. So if you can see the pancreas well, sometimes that is cause for suspicion, especially in the setting of epigastric pain. If you look at the edges of the pancreas, you'll notice increased lobulations, or kind of a scalloping of the pancreas edge. And if the pancreas enlarges enough, you might see it compress the IVC. This last picture of acute pancreatitis shows a dilated duct of Wirsung. Remember that the duct of Wirsung is the main pancreatic duct that connects with the bile duct before entering into the duodenum. In the setting of pancreatitis, we may also see dilated bile ducts, especially if there is a stone blocking the distal common bile duct. We may see stones within the duct, and we may see fluid collections around the pancreas. You will get a lot of orders for possible pancreatitis, and pancreatitis is kind of one of those tricky things. We can see it by ultrasound. We can't definitively diagnose it, but you know when something doesn't look right. You guys have been scanning normal for so long that when you see something that's abnormal, you'll be like, oh, something doesn't look right about that. And that's kind of what ends up happening with pancreatitis. The pancreas just looks different. And one of my favorite non-medical terms to describe it is usually just to say that it looks fluffy. That fluffiness is the edematous part where the pancreas just starts to get kind of enlarged. A lot of times it does kind of appear a little bit brighter. With acute pancreatitis, it'll look a little darker. So it's just going to take on a different look than what you're used to. And sometimes just because you can see it so well, that means that it's enlarged, it's edematous, and so that should kind of clue you in too, as something might not quite be right. But you will quite often get ultrasound orders for epigastric pain, pancreatitis on it. So make sure that you're doing your best to see that pancreas and trying to get that diagnosis for the patient. Otherwise, remember there's always CT to follow up your ultrasound scanning. Now, chronic pancreatitis is actually even harder to diagnose by ultrasound, especially due to the way that the pancreas reacts to being constantly damaged. However, if you do clearly see the pancreatitis and it looks abnormal, then you should be able to recognize what chronic pancreatitis looks like. Chronic pancreatitis is defined as permanent damage to the pancreas. So typically these patients have had several bouts of acute pancreatitis to the point where the ducts and the Acini cells and the endocrine cells are all just kind of damaged from all those enzymatic juices being around and making it angry for so many years. So what we tend to see then with chronic pancreatitis is that these patients have impaired function of their pancreas, and that's going to be affecting both the exocrine and endocrine function. Recall with acute pancreatitis, the number one cause is biliary disease and then alcoholism. But with chronic pancreatitis, the number one cause is going to be alcoholism. And that kind of makes sense if you think about it. Once a person is diagnosed with biliary disease, stones, or pancreatitis because of stones, or cholecystitis because of stones, they're getting rid of that the gallbladder. They're going to take that out. So now if their main cause of pancreatitis was something to do with the gallbladder is gone, no longer causing pancreatitis. Alcoholism, however, left untreated, is typically a lifelong disease for people and is very difficult to overcome. What we do see though is that biliary disease, smoking, and some other blood fluctuations with chemicals like calcium and fats also can lead to chronic pancreatitis, but remember that the number one cause is alcoholism. Chronic pancreatitis doesn't really have any very specific symptoms as far as pain, nausea, vomiting, that kind of stuff. What they might or most likely will have is some sort of transient pain, and that pain can come and go and can be pretty severe. So we'll find that a lot of chronic pancreatitis patients end up on some sort of pain management program. The other thing that we might see with chronic pancreatitis then is because the exocrine and endocrine functions are dysfunctional, we might see some pancreatic related issues. So that might be glucose intolerance because now the pancreas can't produce insulin to counteract blood glucose. We might see that the patient is unable to digest their food. Remember that the pancreas is vital in that as well. And they might not be able to absorb their nutrients as well. Again, kind of going back to the poor food digestion, can't break the food down into its elemental form for the body to use. So with chronic pancreatitis, as with any chronic disease that we see, chronic diseases tend to make our organs shrink down on themselves, and chronic pancreatitis is true to that too. So the pancreas is going to appear kind of small or atrophic. So awesome, already can't see the pancreas half the time, now it's even smaller. But keep that in mind, if we've got a patient that might have chronic pancreatitis, you might not see it. If you do see it though, it will most likely be very heterogeneous. It's going to look kind of gross. And we might see some fibrosis in it. And fibrosis typically looks kind of like these strands of white going through the through the tissue. If you happen to click on the link for Calcifying Pancreatitis, you already have heard some of this, but the pancreas, because again of those chronic changes, what ends up happening is that calcifications start to develop, and we see this in other organs as well, but pancreatitis, especially chronic pancreatitis, can definitely lead to these calcifications forming. So if they form, we'll actually see a very echogenic pancreas then, and we'll see those bits of calcification throughout the pancreatic tissue. There will be a little bit of shadowing behind those calcifications if they're large enough, and it can easily be confused with just gas within the bowel in the area. Now, just like with acute pancreatitis, with chronic pancreatitis, we can see a dilated duct of Wurtzung, and we might see some dilated bile ducts if those are still present. We might see stones, again, down by the ampulla of Vater, and we might see some fluid collections around the pancreas as well. The big thing with chronic pancreatitis, though, is that there's just been so much damage to this area, so much of those digestive enzymes leaking out into the area, that actually really starts to irritate and affect the portal confluence, which is right next to the pancreas. So remember that the portal confluence is the joining of the splenic vein and the superior mesenteric vein coming together to form the portal vein. And because of all that irritation in the area, what we might see in our patients is portosplenic thrombosis. So that would be a clot that is formed within the portal vein or within the splenic vein as it courses near the pancreas. Now, a set of your key terms for acute pancreatitis is to understand how acute pancreatitis is classified. We have mild, moderate, and severe acute pancreatitis. The mild form is probably going to be the little bit more common form. Typically, these patients are going to come in a little bit sooner once that acute pain sets in. The pancreatitis is diagnosed, and then they are treated appropriately and sent on their way. So mild acute pancreatitis really only involves the pancreas. The pancreas is still functioning as expected. There is no organ failure of the pancreas or of other systems. Now, moderate acute pancreatitis is going to show that there is some change to how the pancreas functions. And so that's that transient organ failure. And what we will see is decreased function of the pancreas at times. So the transient means it comes and goes. And lastly, severe acute pancreatitis, we're going to see persistent organ failure in one or more organs. So not only is the pancreas going to be non-functional, we're going to start to see the effect in the liver and in the kidneys. If you listen to the introduction for acute pancreatitis, I had mentioned in there that ultrasound is not maybe the best test to diagnose acute pancreatitis. And it happens to be that contrast-enhanced computed tomography, or CT, is actually the best way to diagnose pancreatitis. The pancreas is well visualized, and it is even better visualized when we use an oral contrast. The oral contrast usually has some sort of barium in it that helps to coat the insides of the GI tract, and with that, then air within the system is reduced, therefore showing the abdominal organs in a more clear fashion. The pancreas is then able to be visualized in its entirety, and fat stranding and changes to the pancreas are able to be seen to better diagnose pancreatitis. ERCP stands for endoscopic retrograde cholangiopancreatography. And what happens with an ERCP in the setting of pancreatitis is that a patient is put to sleep and a probe or camera is inserted in through the esophagus, down into the stomach, and then into the duodenum. The duodenum opens to the ampulla of Vater, where a small tube or catheter is inserted through the ampulla and into the either bile duct, if we're looking for blockages there, or into the pancreatic duct. Once that little catheter is placed, dye is put in through the catheter, and then X-ray is used to see how the dye fills the ducts. If there's a stone in that area, it can be seen as a filling defect in the pictures created by the fluoroscopy. A presentation of chronic pancreatitis that we sometimes see, especially with alcoholism, is calcifying pancreatitis. And with calcifying pancreatitis, there are basically like little stones that start to pop up in the pancreatic tissue. And this is due to the damage that the enzymes create, just that over and over and over again damage occurring irritates the parenchyma, and the tissue just starts to harden and makes those calcifications basically. So we can see that on ultrasound. We'll see some shadowing through the pancreas behind some echogenic foci that are scattered throughout the parenchyma. As you can see on the CT picture here, it is seen very well bright echogenic areas within the pancreas.